All right. So the outline, you notice there are 2 slides that I've kind of flipped around in here from the printout that you have, the first one being the next one. I kind of took that out. My feedback from the time I gave this before was we don't need to know what's happening on the cellular level, so if you would like to, it's there in the printed version. Otherwise, I'm not going to spend much time going over it. If you have any burning questions again, I'm more than happy to talk to you after. So what I do tend to go over in this presentation is what is happening to the skin, what's relevant that you guys should understand about what's happening and changing in your skin. What can you guys do without needing a physician to be involved or a nurse practitioner? Little things on a day-to-day little changes that can make a big difference to how your skin feels and goes through any changes, as well as then what can the doctors do to help? What could they be doing? What should you kind of expect them to be doing to help with the skin portion of things? As well as at the very end, I get to the actual wound healing in the ulcers that do show up as a part of this condition. So the skin tends to go through 3 phases of change with the systemic scleroderma. The first one, and this is where a lot of my patients will come in, and the way they'll tell is that I wake up in the morning and my hands are stiff. They're really swollen and they're really stiff. It takes me a while to be able to get them going and moving again, and they don't quite understand what's going on there. They're painless, thank goodness, when they do start to have this phenomenon happen. In some instances, it'll last longer as the day goes on. That swelling takes some more time to start coming down. When it does, and if it does, start to head up the hand enough into the wrist, sometimes the swelling can start to push on the nerve that's in the wrist a little bit, and you get that carpal tunnel feel. So you get that shooting pain sometimes. Not everyone has this phenomenon happen, but if you do, a lot of the time it's because that swelling that's happening in the wrists. You'll get some of the edema where if you actually push on the top of your skin, you'll get a little bit of a dent or a divot, and it takes a second before it kind of pops back up again. That's all the beginning signs of this phase happening in your body. Over time, because these changes happen and they stay, over a period of time, you do get some thickening of the fingers and the skin on the fingers, as well as the fingernails in some instances will also start to get a little thinner and a little more frail because the circulation is not getting to them quite like it was before. So eventually, when the changes do become more of a permanent fixture to the day-to-day, what happens is that skin becomes very tight and shiny. You'll have less hair that will grow in it because of the hair follicle changes that occur as well. In some instances, there's a lot of itching. And it's the body's way of coming and saying, there is something going on here you need to pay attention to, and you are very well aware, but your body doesn't know you're aware. So you get a lot of that itching that happens initially as well. A lot of the time, manageable with some Benadryl. Over the counter, again, as long as it's taken as recommended. Benadryl and sometimes a low dose cortisone. So something like a hydrocortisone, either 0.5 or 1%. Patients are still able to go and buy that and apply it maybe once, twice a day. Sometimes they'll do a combination of both, the Benadryl and the hydrocortisone, until it's able to be more manageable. Likely what's happening truly is the inflammation of the blood vessels because of having that edema around them. That's why they have that itchy, irritated feel to them. And when I talk a little bit later about the things that irritate the skin, our acid mantle and maintaining those, that also plays into this phenomenon as well. So phase 2, this is when the thickening will happen, that more permanent changes to the skin in your hands, and then progressively it does tend to go to the neck and the face next. You'll notice that you have a little more decreased skin or hair growth that happens in these areas as time goes on as well. And the lips will sometimes have that pulled feel to them. In the localized scleroderma, so the morphea, I have a lot of patients who only have the localized portion of things. Sadly, over time, though, sometimes they get wounds there, and they're very difficult to heal once a wound opens over this area because it's already thicker. It doesn't have that natural cell formation in it like it once did to skin that hasn't been affected by the scleroderma. But good news is, if we identify it early and manage it quickly, it can go into recession as well as be prevented of further reoccurrences down the road. There's 2 ways that they do show up. Either the circumscribed, I always say circumfried, I don't know why, circumscribed, which it tends to be more the circular patchy areas that come up on the trunk. Sometimes it'll be on the legs and the arms. The other is the linear, which tends to sometimes be a little more deep. So not only the skin, but it tends to go into the fat tissue and the muscles sometimes. Being careful of those when they do come up on the skin, because if they go towards a joint, it can actually start to affect the mobility of that joint. So that's the big thing we usually focus on with those, is trying to get it before it gets to a point where it's affecting the mobility of the patient and their day-to-day ability to move. So that's the circumscribed. So it starts as kind of more like a dark purple, red color that comes up on the skin. Over time it hardens and starts to expand in the size, and you sometimes get alternate size. As soon as I tell my patients, especially sometimes they come in late diagnosis after this has been sitting there for a long period of time, so it's a little harder for us to get a control over it. But if it's a reoccurrence, I tell them as soon as you start to see any little thing come up on your skin, come on in, we'll start you early to keep it from becoming more of a harder problem to rein back in again. This is the linear. Wait, I have my pointer, where is it? There we go. So sometimes it'll happen along the scalp, and this is where it kind of linear and comes down and affects the ability of the knee to function as well, because it'll get tight and thick, and then the ability to bend starts to reduce over time. I know this is a lot, don't worry. I put this up more or less just so you guys can appreciate there is a thought process that goes with how we approach, as a medical professional, how we approach the different kinds of therapies that will follow when someone comes in with any lesions related to scleroderma. We consider how long has it been there. Has it been more or less than 6 months? That changes how aggressive we're going to be, as well as where we're going to start off. Is this the first lesion, a reoccurrence? Are they having effects elsewhere in their body? Is it just the localized, or do they start to have some more of the system-wide concerns? What's their body's inflammation state like at that time? Are they generally inflamed, or is it still just that one area that we're focusing on? Is it superficial or is it deep? So once we've kind of determined how long it's been there and the severity of it, now is it just affecting the top layers of the skin, or is it now going deeper into muscle? If it's superficial and in one spot, a lot of the time we can use topical creams and things of the sort that will help to control the inflammation right there at the site, as well as phototherapy. UVA specifically, which we can get plenty of in the sun. I'll talk a little bit later about why we recommend this strongly for some patients, maybe a little bit more than others. In Canada, we only have the sun really for about 5 to sometimes 6 if we're lucky. So we have to have clinics where our patients can go and be able to expose themselves and not freeze to have the benefits of the phototherapy as well. If it's generalized, we can still do the UV therapy, but we'll also consider putting in medications like methotrexate and things of those to be able to bring the inflammation down from a systemic level. Other thoughts, so that's the medical mumbo jumbo, but we also take a look at the other considerations, such as cosmetic. Is this affecting, your quality of life? Is there something else we can do that way for it? As well as, again, that OTPT, and do we need some kind of assistance with being able to continue with the mobility in that joint? Do we need to go in there and free up some tendons so you be able to still walk and extend certain limbs? So things that, again, we go on and consider, but a lot of the time, if we can catch things early, there is still that opportunity to reel it back in before it starts to affect the deeper layers. So immunomodulators, big word for medications to keep your body from damaging itself. Ultimately, that's what the goal is of these. Methotrexate, again, it's a personal favorite of mine. It has in my experience, for when I'm dealing mostly with skin conditions, it has the least number of side effects and it is the most effective in my patients. If they have other systems systemically being affected, in those instances, a lot of the time I go to my rheumatologist and I collaborate with them very closely for those patients. If it's just a beginning, nice and early, I'll usually go with just the pill form. If it's a larger flare or it's a deeper tissue layers, I will go with IV for periods of time until we're able to kind of get it under control and then switch back to the pill form. The two ointments that we can use just locally, I actually start with the second one there. I can never say it right either. Calcinosis. That one is ultimately a very complex vitamin D, so it has less side effects than the tacrolimus, which is an actual medicated cream. So I tend to go with that. If I don't see any effects after about 10 to 14 days, then I'll go over to the tacrolimus. But a lot of the times, I'd say about 50% of the time, we'll start to see some changes just with the vitamin D. It usually takes about a month for it to really resolve the smaller lesions, and it leaves the skin softer than or prior to when the lesion had started. So the phototherapy. We use it, but again, not if we'll use it sometimes in conjunction if it does go into the deeper levels, but it won't actually assist because it doesn't go past the dermal level, so it won't impact what's happening in the subcutaneous tissue and the muscles at this point. But we can still help what's going on the dermal level with it. How it helps is it actually increases the enzymes in your skin that will break down collagen. At the same time, it'll also decrease the enzymes in your skin that produce that collagen as well. So it's a bit of a double whammy. It's fantastic. I find the best way to explain to anybody when it comes to the local treatments of any skin changes with scleroderma is that if our society labels it as something that's going to age your skin, then we want to be able to do it when you have scleroderma. It is the opposite of anti-aging. Because it is that collagen buildup, and with the skin's aging over time, what's happening is a lot of people's collagen as they age and they lose that fullness to their skin is they're losing that collagen. In the instance of scleroderma, there's an overproduction. So anything that's going to be anti-aging, you should actually be staying away from because it's triggering that collagen production further in your skin. If society says it's going to age you, go do it. That's how you guys, if you don't take anything else away from today, that would be your main key. Everything else is just kind of specifics. All right, so great in the fact that it's playing with our enzymes, breaking down the collagen further and preventing the collagen from coming back as quickly. The considerations, though, are you do sometimes, because the treatments are very intense for about 15 minutes. You're not wearing any sunscreen or anything clearly during this therapy, so there is the chance that you're going to run like a first-degree sunburn. So in some instances, patients who have had lifelong exposure to sun a little longer, they don't seem to have much problem. Me, I'd burn. I'm bad. So there is that consideration going into it. The other consideration is the herpes virus can be triggered by the UV therapy. Very rarely, but enough that we do mention it, so we watch very closely when we do initiate this therapy for that purpose. And yes, it will accelerate aging in that vicinity. It won't actually, the UVA spectrum won't actually permeate past the dermis, so it won't go into the subcutaneous tissue. So it's not that it won't do anything, it's just that it won't reach that far. So, okay, so the phototherapy, 15 minutes, pretty much Monday to Friday, 5 days a week for about 8 weeks. These are some of the subjects that have been assessed. They have visual improvements, the tightness improves, as well as the itchiness significantly decreases with these areas as well. So on ultrasound, they can actually tell that the skin has thinned as well in these areas. So it's not just our visual, but it's also quantifiable with ultrasound. So this one actually goes back to the hands as well. This was like a small pilot. This is not exactly what we would call best evidence, but I've recommended it to my patients because the risk is very low for any harm. But at the same time, I've had good results with my patients who have unofficially done this and said that it helped them significantly. Was either using paraffin wax, or some patients will do it just in warm water at home. It's 50 degrees Celsius, so I did the translation. I have an app for that at home. Before I came down, it's about 110, 115 Fahrenheit. I like the paraffin wax because you can control the temperature a lot more than if you just use a bucket of water at home. But because of the warmth, it will actually open up those capillaries in your hand and allow that circulation to come in. Not only is that then going to feed into your hands, but it will decrease the swelling because there's a way for that circulation, that blood to actually now get out of your hands as well. So doing that, not just letting them sit there, actually moving them a little bit, help them with that return quite a bit. In the control, they did it for 30 days. They did one hand they submerged, the other hand they didn't, and they did notice that there was a recognizable difference from the hand that did to the hand that didn't. So feel free to, very low risk, unless you have an open ulcer. If you have an open ulcer, I wouldn't recommend this at this point. But if you still have just the swelling and the localized kind of thickenings that's starting to happen, this is a good exercise to do every so often.
And also,
Yep.
And also, it's not only inside, but also to keep it outside for a few minutes. Or...
If you find that it's starting to feel uncomfortable, take it out, and then
And then again.
yeah.
So how long would be fine?
About 10 minutes, I'd say. So if you say, 10 minutes can be a long time when you're sitting and doing something uncomfortable. But again, taking it out. Sometimes do it maybe while you're doing something like watching TV, so you're not fixated on your hand being in warm paraffin wax. But again, be aware, listen to your body. Anytime you ever do anything, listen to your body. Is it telling you this is too much? I don't want to be doing this anymore. Definitely tap out. This just isn't for me. Some people have a great response to this. Some people, again, it's not for them.
And it's the same for foods.
Feet, yep, if you want to do that. Again, the only thing I would consider with this is if you have diabetes, I wouldn't be submerging your foot for more than about 5 minutes at a time. There was another study as well. You can see this lovely lady here is modeling our pneumatic arm device. So what this does is actually, these are different air-filled balloons, pretty much. And what it does is it helps to push circulation up and push circulation back, up and down the arm. Again, this is expensive and kind of extreme. But that being said, in some instances, there were good outcomes when you do it for a total of 5 hours, not 5 hours sitting down straight per day. There's a 96% healing rate of ulcers that had been non-healable because of the additional support and with the circulation being assisted up and down the arm to that limb.
Is that ulcers on the hands?
That's for ulcers on the hands, yes. So getting kind of into the skincare portion of it. So emollient creams. So these are kind of your Vaselines, your mineral oils, anything petroleum-based. They're thicker, they're greasier. And what they do is they actually trap your own body's moisture into your own skin. If it's just strictly an emollient, a lot of the times it won't so much lend moisture to your skin, but it does keep your own skin moisture in quite well. It's a little on the greasy side. It might be a therapy you'd prefer to do at night before you go to bed, so you're not walking around with, depending on what area of the body you're focusing on and applying it to. There can be different kind of forms, creams, ointments, gels, depending on kind of the consistency of it, if there's other things blended into it. Things like gel tend to have a little more water base to them as well. Creams usually have other moisturizers, vitamin E, that kind of thing all in them. But the emollient part is what's important for trapping that moisture into your own skin. It'll also help with reducing the amount of itch. We talk about pH in a second, the skin's pH, and how that's important and ties into the itchiness. Oh, I guess it's after this slide. So the other thing is urea. So things like Urea creams or Eucerin. Urea actually in the body, what it does is it attracts water to it. So if you're, again, trying to attract your own body's water and moisture up through the skin, up to the surface where it's depleted, by having Urea on there, you're actually naturally attracting your own moisture up into that layer of skin at the top. So a lot of the creams will come in like a 5%, 10%, 20%. I usually will recommend to any of my patients that they start with at least a 10 if they can get their hands on a 20. Prescription-wise, I can give them a 50. So anywhere, if moisture is your main concern, urea is a great way to bring your moisture up to the surface. It does help to protect the pH of your skin. Your skin's actually happiest being slightly acidic. And I talk about that, hopefully, remembering my slides. It also acts a little bit as an anesthetic. It soothes quite a bit at the skin, so it helps with some of that itchiness. In my patients who are on dialysis, actually, we use a combination of urea because their skin is in quite dire straits and don't have enough of it, so it actually helps with their skin quite a bit. Yes.
And do you recommend a special brand?
In Canada, we have Uramil and we have Eucerin, generally. Eucerin, you guys have Eucerin down here? I believe I've seen a commercial for it once or twice since I've been here, so I'm assuming yes. Okay, like I said, and that comes in, I believe, different strengths as well, so just paying attention to the strength of urea that's actually in there. Okay, so pH. So your body has a natural shield that it's trying to protect, and it has several functions to it. So it shields your body from bacteria and pollutants from getting into it. It regulates your moisture and your oil balance on your skin, as well as it helps to regulate your sweat glands, which as scleroderma progresses, the sweat glands are affected and are less and less effective as time goes on. So again, mentioning your skin, to be able to function like that, this acid mantle likes to sit at about a 5.5. Now, chemistry lesson, water is about a 7. It's considered neutral in nature. So that means even if the only thing you put on your skin is water every day, you're already actually throwing that off a bit. So it's important to try to find products that are pH balanced that will help bring your skin back to that acidic base to start with. So moisturizers, cleansers, that kind of thing, if you can find things that are pH balanced, it does make a difference. That includes things like shampoos as well. You have the largest pores in your body are on your scalp, so it can be very, very irritating. And your acid mantle does extend up there. So kind of a, you guys hopefully in the back if you can't see, but it's on your slides. So if you have a normal pH, your cells are well organized at top, so you have a better protective layer from things getting in and irritating. Your moisture is more likely to stay in your skin where it should be. The other thing too, and this is very important for the itchiness and the irritations, is your nerves stay well past into the dermis where they should be and don't track up to the epidermis where they're more sensitive to anything they come in contact with. When your pH is disturbed, those nerves find a way of getting closer to the surface and become more sensitive to anything that touches them. So things like that ridiculous itch that you just can't get under control, and you're putting hand cream after hand cream, if that hand cream isn't pH balanced, you're just kind of encouraging it. And if there's anything that your body is naturally going to be irritated by to begin with in that cream, now you're also bringing that to the nerves that much faster and irritating it. It becomes a vicious cycle. So what to avoid? So this is all of the catchphrases from things like oil of Olay and Aveeno. Retinol, retinoid, retinol A, which are all components of vitamin A. So stay away from A's. Vitamin C, another one, it's used in collagen building, so you don't want to be having an overabundance of vitamin C on your skin, as well as alpha hydroxys. So some of our ointments and creams will have alpha hydroxys in them. It's quite a good agent for rebuilding that collagen, but again, you guys want to stay away from that. The other thing, not related to collagen per se, but again, that irritation of the skin is the sodium lauryl or sodium lauryl sulfate. It's usually the second or third ingredient in a lot of your skincare products. Usually what I tell everybody after this session is to go up to your suitcases, take a look at all the stuff that's in your shampoos and your creams and your soaps. Take a look at how much of this stuff is really in there. We're so conscious of what we take into our bodies, what we eat every day. What's in our skincare products isn't regulated nearly as strictly as what we eat. So watching what's in there is very, very important, especially for you guys.
So we need to stay away.
Yeah. So the role that this plays is it's actually a surfactant, so it lifts dirt very efficiently. The first place that we actually used it was in the industries to get grease off of like garage floors. And then we refined it and put it in our skincare. The other thing that it does is it makes things look foamy. And we've kind of come to believe as a society, in order for something to be clean, it needs to foam up and look really bubbly. That's what this does. And that's why it shows up very often. So if you have something that just lathers but doesn't go bubbles, that's this general ingredient. So what it does, if you even look at like its medical data sheets, or materials data sheets, it's actually listed as a major irritant. So, and we're putting it all over our skin. The Lancet actually documented that It damages the skin barriers, so that acid mantle we were just talking about. It alters the actual cells themselves, as well as it enhances any of the body's natural allergic responses to stuff. So it's an irritant. And that's the last thing that you guys want going on in your skin. That'll cause further inflammation happening and lead to that unfortunate cycle of things. Actually, it's also in your toothpaste. Canker sores, if anyone suffers from that, take it out. All right, so you can tell it to your loved ones who might not have scleroderma and need to be as aware, but these are all things that affect everybody. I took all of these things out of my skincare products. I don't use any of that stuff. And my skin's better for it as well. So the third phase, and this is the one that sadly by the time I see them the most, because I work primarily in hospitals, so a lot of my patients have come in with more severe cases. Sometimes they'll come in with another cause and happen to secondarily have some concerns with their skin from the scleroderma, but sometimes they do come in with the digital ulcers or with wounds that have come up on the lower limbs, that kind of thing, for us to manage. So this is the atrophic phase, is actually where the skin might soften a wee bit from when it's in the thickening phase. Sorry, I should have grabbed water before I came down. The other thing is the spider veins, the little kind of bursts of capillaries. Sometimes it will happen in the face, sometimes it'll happen in the hands. Those are the two places people tend to notice it the most. The calcinosis. So this is another one that a lot of my patients will come in with those calcium deposits that happen primarily in the fingers. Sometimes it can happen up into the forearms. I've even seen it in the buttock area in a few instances. Then there are the painful digital ulcers that come up with the Raynauds, the hypo and the hyperpigmentations, as well as just the general pruritus given over time because of the excessively dry skin, because of the changes, as well as the sweat glands decreasing. So, praise. Itchiness. Okay. Sorry. Technical term for itchiness. So, what's happening is, again, with the vasoconstriction that happens over time, with the condition, eventually your blood vessels in some instances just say, I've had enough, and they just fully give way. And you end up with these small kind of spots, really, really close up. What it is just the blood vessels have ultimately kind of hemorrhaged out the ends. Not painful, but also not pretty. Some people have concerns with these, especially when they do come up on the faces. Some of them are smaller, some of them do take up significant areas and are concerning for some people. So the biggest thing a lot of the way is subtly, you can use foundation that has a bit of a green tint to it. On the color spectrum, red, the complementary is green, so it's actually the one that will dim it out. If you try to just put regular concealer over it, it just kind of splotches on but doesn't fully affect it. Using something with a green tint to it will actually help to bring the redness appearance down. Now, if it's a larger area and you just can't go through enough foundation for that particular spot, there is the laser treatment option that will eventually clear out the blood vessels. The calcinosis. So eventually, or in some instances over time, you'll get calcium deposits. On x-ray, you can kind of see the white areas. So here's your bone, and you can see how it shows up a little whiter. So the calcium deposits show up really thick and white here. So they've actually got quite a bit in their joints, one little one there. And eventually, if they do come through the skin, they tend to look almost like little whiteheads to start, but they are very solid and fixated. Pardon me. Usually, generally, most of the time, it is the fingers that they will develop in. That being said, again, it's not reserved to that, so keeping an eye out for anything that might be starting. Oh, thank you.
I was presenting earlier.
Oh, excellent, thank you. It's getting a little hotter in this room as it goes on as well. All right. Oh, perfect. So yes, where was I? So we don't fully understand exactly why the calcium deposits in this area. So preventing it is a bit of a challenge when we don't quite understand exactly why it occurs in the first place. In some instances, using gout medications. So allopurinol is usually the one that I'll use. The other one that's listed up there that I can never pronounce starts with a C right there. So some are familiar with it. I believe it's used more frequently in the U.S. It was a U.S. study that I pulled this one from. So allopurinol is good for treating this phenomenon in the fingers. So usually it's gout that it treats, but it also has been, yeah. So it helps bring down the inflammation. To actually reduce, if you catch it early enough. So again, if you're very vigilant and you notice little things kind of starting, you can feel them underneath. They're very, very small, almost like grains of salt. I've had my patients describe them as. There you go. Ask this lady right here. So it, sadly, I'm sorry. But as it comes up, if we get it early, and within early, I mean like within the first 2 weeks of them starting to develop, using a low dose of Coumadin or warfarin, which is actually a blood thinner. If we use it usually about 1 milligram a day, it can be effective. Actually, sorry, it was within 2 months. So if you notice it and are able to get in to see a doctor within 2 months and they're savvy and you can be like, hey, I went and I heard this woman talk at some point. All of the references that I get, so I think it was Sparsa that actually had mentioned the warfarin study. Being able to bring that sometimes to your healthcare professionals has more weight than I went to this conference. I heard someone speak and they want to put me on warfarin. There are substantial risks that do come with it because it is a blood thinner. So there are certain cases where it might not be appropriate, but for those cases where it has been, there haven't been any outweighing risks to the patients, they have noticed that with 1 milligram per day that it actually does bring down the calcinosis when we catch it early. If they're larger areas, however, or it's been there for longer than 2 months, there really is no difference in the, so. That being said, if there's instances where ulcers start to develop or the pain becomes increasing and uncontrollable, in those instances, what we'll do is go to, I have a great plastic surgeon that I work with who will go in and actually scrape the calcium deposits from the bone so that it's no longer wearing against the skin. And the healability and the rehab for that actually is quite good. They do come back. And they're already starting to, yeah. After the debridement and after you're healing up, it might be worth you to consider the warfarin, to consider that. Right. So the hyper and the hypopigmentation tends to be more of a cosmetic concern than it does overall being any kind of functional or pain that comes with it. So a lot of the time it's either laser therapy or again, just kind of finding the right, depending again on the size of the area and the location of it, finding some way of cosmetically either with a foundation or with clothing, covering it up. I've even had patients go and get tattoos. Very meaningful tattoos, but a good tattoo artist in some instances. I'm not prescribing that or recommending that as a medical therapy. I'm just saying this is how some people have gone about it. Okay, Raynaud's. Oh, and I'm actually doing decently for time. Excellent. Okay, so Raynaud's, still very complex. There's a lot of things going on with Raynaud's. Not only is it now the skin has thickened over time, what's happening now is the vessels themselves, the inside walls and the layers of the vessels are also thickening, which decreases how much blood is able to actually travel through them. We have that immune response going on as well, so it's an easily triggered inflammation. Once it starts, it's hard to kick back out again. And you have the episodes of the vasoconstriction. So ultimately what's happening is the small blood vessels will clamp down, and it's the body, ultimately, it's the fight or flight reaction. So you already take this very narrow pathway, and your body, as remarkable as it is, cannot make the discrepancy between you running for your life and it needs to clamp down to save you from blood loss, and you've been out in the cold too long and you're not going to die of hypothermia, but your body doesn't know that, so it just automatically clamps down and says, in order for you to survive and keep all of your blood near your organs where it needs to be, we're going to close down to the peripheries. For me, that's just really, really uncomfortable. For someone with Raynaud's, it could be the difference between losing several of those digits. So, and because the body then goes into an inflammatory phase, and it's harder to get someone who's in that phase already out of it, the damage could be ongoing even after you start to slowly warm them up. It's a lot harder, again, for that reaction to slow down and stop. So there's cold is the big one. Again, Canada, -30. New Orleans, not maybe the biggest trigger that you have. But that being said, you might hold a cold drink for a period of time. Poolside, cold drink. Other situations, stressful situations, whether it's work, some bad news, anything else, your body generally goes into an inflammatory stress response. It will start to affect your fingers as well. So stress management is actually something that I try to help my patients, and I refer on to our mental health in a lot of instances, because it does play a part that people don't realize on what's going on, even their fingertips. So just to kind of get a sense of things, this slide isn't in the one you guys got. I do apologize. I literally stuck this in not even an hour ago before I came down. Just so you guys can appreciate really how the blood flow looks in your hands. So these are all the arteries and the blood flow into them. So it's great. You can see the really high uptake in your fingers, which is fantastic. It helps with the sensation, your tactile feel and other things. Sadly, that does mean the skin on those fingertips get used to having a lot of blood flow to them. So when they start to, over time, decrease, they're used to having it, and now they don't. And it doesn't, sadly, take much. So the approach to digital ulcers. Anything that I underline largely has a part to do with things that you guys can do. So keeping warm, big one. I noticed you guys got gloves in your bags. It's a real thing. Keep them nice and warm. If anything, the warmer the better for those fingers. Smoking cessation. This is a big one. My patients, whether it be digital ulcers, diabetic foot ulcers, leg ulcers, pressure ulcers, any kind of wound in general that occurs on the body, smoking will significantly decrease the healability of those wounds, and in some instances really provoke them to either worsening. What's happening with the smoking is the nicotine effect is that it does vasoconstrict quite significantly. So fingers, everything. So if it's already at risk and then one smoke, vasoconstrict. It takes your body about 3 to 4 hours to release from that. So if you smoke every hour, every 2 to 3, your body's still never really fully having that opportunity for that blood flow to restore back to those extremities either. So smoking, even if you smoke 3 or 4 cigarettes a day, you're really never giving your body that opportunity to recoup in time other than when you're sleeping. I have known patients who have woken up to have a smoke in the middle of the night. So in those instances, if quitting was ever a consideration in your mind, please follow it through. Yes. Secondhand smoke still affects, but not to the same degree. You're getting more of the issues with the lung inhalation. You're not getting that full burst of it, but you are still getting a diluted version. I'd say probably about a half an hour you might get that vasoconstriction worth because you're not fully appreciating it through your membranes in your mouth, but still will impact. So, was it smoking? Yes. I have had patients who they're like, this is my only pleasure in life at this point. I've lost my feet, I've lost this, I've lost that, even though no one told them before they lost their feet that it was an issue with their smoking. But that's their one thing, that's how they cope. So again, it goes back to quality of life. My job is to educate and support. Ultimately, the decision lies with you. If you want to, that's just something you can't give up and you're holding on to that, then we work with that. Now, activity level. A lot of the times, whatever your baseline mobility might be. So I'm not saying if you can walk, please keep walking. Don't go bedbound. What we're saying is don't run marathons where your blood vessels or your blood pressure is going to be ridiculously elevated. So if you're doing anything that you feel like you're starting to get quite a heart rate up, trying to bring it down, again, because that fight or flight phenomenon in the body happens. And again, it will close down to reroute all of that blood circulation more to your large muscles, not so much to your fingertips. But again, moving consistently, walking is fantastic. There's a lot of benefits to your circulation on that. We're just saying don't take up marathon running at this point in time, if that's a possibility. The other thing, if you happen to also have diabetes, where do you guys test your sugars? It tends to be, because of that lovely picture I just showed you, there tends to be a lot of blood in the end of the fingertips, hence why we do that. If you poke yourself in the arm, are you also going to bleed? Yes. Are you going to likely develop an ulcer, though, if you poke yourself in the arm? My patients who are at higher risk do not poke themselves in the finger, because what are you doing? You're breaking the skin, you're giving a portal of entry, and you're injuring and causing inflammatory responses right there at the site. So, plus, with the diabetes, if sugars have been a challenge to manage over a period of time, having high sugars will also damage the inside layers of those vessels to begin with, so you might already be having that built up damage to the inside of the blood vessels for years already. So adding literally insult to injury, being very, very mindful. And one of those little changes that I find my patients will have, especially with recurrent digital ulcers, if not checking their sugars on their fingertips, moving somewhere to their forearms. That also being said, I can appreciate patients who are on steroids. It does become more challenging to balance sugars because steroids make it also ridiculously difficult, and the way that it affects the hormones in the body. So trying to keep them within a good tight range, because over time it does continue to damage those small blood vessels as well. So it's kind of, again, another layer of prevention to keep in mind. Blood pressure and cholesterol. Again, cholesterol, you could be having those plaques build up on the inside of the arteries. It doesn't take much for one of those guys to go flying. If they happen to, usually it's feet more than fingers. If there is going to be a plaque that sometimes let go, it'll sometimes go to the feet and cause issues with the circulation in that area. Plus blood pressure. If you think about it, you got your little vessels. What's coming up, the blood pressure is kind of rebounding and back, rebounding and back. If you have a high blood pressure, you're pounding on those little vessels that are already very friable at the ends. So decreasing and having a good, healthy blood pressure makes a big difference in how well your extremities will heal as well. Okay, some of the slightly more medical components of it are the dressings. Seems to be what most people are fixated on. What do I put on my open wounds? There are three major kind of go-tos that I'll recommend. A lot of the time, Polymem is the first one I go with. It actually has an anti-inflammatory polymer in it. So not only are you likely on some kind of systemic anti-inflammatory, but this one will drop it right into the local area of the tissue. So if you're having issues with circulation and you're taking systemic medication, if your circulation isn't actually delivering it to the area of concern, it's not working. It might be keeping it from getting the damage further, but it's actually not necessarily always helping if that area is already being affected severely by the inflammation. So putting it on locally right at the site will also help support that body's fight already. It comes with silver, so antimicrobials, plus it has a glycerin layer to it, so it actually allows for some moisture, not only for the surrounding skin that tends to be really dry, but it'll also add a little bit. It's one of the emollients, glycerin, same as mineral oil, that kind of thing, so it'll help to soften the skin a bit so it's not as dry and angry, especially with those ulcers. I compare wounds to my front lawn. You want them to be moist. You don't want them to be ridiculously dry, because if you think about grass, ridiculously dry, not watered, it's going to dry out, nothing's going to grow. You're not going to get any cells, you're not going to get any rejuvenation, you're not going to get any healing if it's dry as a chip. You add a little moisture, it gives your new cells a bit of a medium to grow across. You make it too moist, and it's bogged down, and it's almost that I've been in the bathtub too long when your fingers get all pruny. If the cells in your wounds get too pruny because there's too much water, it's also not a good thing. The other thing too is bacteria will thrive if there's too much moisture, and they tend to thrive quite a bit as well on dead tissue. So if you have the digital ulcers that you have the little black areas on, because your body no longer has any circulation, it can't deliver those white cells to actually kill bacteria, they can take up shop and you're not doing anything about it unless you're actually doing something right there on site. So that's why keeping a good balance, plus also addressing the bacterial load, which the Polymem does wonders with. Manuka honey, so Medi honey. I know people like honey, really? Don't use Billy Bee honey. There's a lot of it. I've had patients. They're like, I was told to put honey on my wound. Don't use like over-the-counter Billy Bee. There's a lot of preservatives. There's a lot of actual added stuff to the Billy Bee honey or any other commercial honey, really, that could cause irritations and inflammatory. Manuka honey, you can actually buy at health food stores sometimes if you're not able to get the medically sterile version of it for whatever reason. If cash tends to be tight, this tends to be quite a good way around it, is getting the Manuka honey, just putting a dab on it once a day, cleaning it off really well, putting a dab, covering it up. Tends to be really great. It's actually got a wide, broad spectrum, so it kills a lot of different bacteria. It adds a little bit of that moisture. Plus, it's an actual anti-inflammatory. There are dressings out there that are pro-inflammatory that will actually irritate your body more by putting them on. Usually, a lot of the time, the iodine dressings. Providine, Indine, Iodosorb. A lot of those, anything that's pretty much a brown or orange in color has iodine in it, and it irritates quite a bit, and it starts to throw, again, things into a bit more of a tailspin. Yep. Pain management is another piece. I'm not going to deny that these suckers are painful. That being said, fight or flight. Your body feels pain that's ongoing. It will further vasoconstrict to that area. Not something a lot of people think about. The other thing is that pain will kickstart your entire body into inflammation as it goes on. You have your cortisol starts to rise, which is your stress hormone. As that continues to rise, your whole body then is at risk of anything inflammatory. So pain is a big piece of a lot of, really, 5? Oh, it is. Ooh. Okay, thank you. I thought I had more time. Okay, I'm almost there. To be honest, I'm almost there. So systemic and pain. So pain management, if it needs to be beyond an NSAID, something like an Advil, Tylenol, that kind of thing. My patients, I do sometimes put on neuro pain agents like Lyrica, gabapentin. Sometimes you guys see them advertised more for neuropathic pain related to diabetes. I use it because it's the same kind of pathway that's being irritated a lot of the time. There are some side effects, so there's definitely considerations when we do that, but it is very important to also manage the pain in these wounds for the ultimate outcome. In some instances, if they have contraindications to narcotics and the neurotransmitter medication, I'll use actually a numbing agent right at the knuckles. Tends to help quite a bit, just numbing those nerves more at that level. Aggressive vasodilation. So oral calcium channel blockers, which is actually an antihypertensive, so it helps with blood pressure. So if you have high blood pressure already, this is a great kind of mix for you, because how it works is by opening up those blood vessels, so it's a vasodilator. So it already is acting in your body to help with decreasing how hard your heart has to pump to get blood pressure around, but it also then opens up your fingers quite a bit. That being said, if you have low blood pressure, not a good one for you. So this is, again, why we don't just put everybody on all of these miracle medications, is there's a lot to consider. And that's why a team approach, if you're lucky to have a good team, that's really who's going to get you through the best. The other thing is IV prostaglandins. That actually not only vasodilate, but they also bring down platelets, which is the little guys in your blood that help to clot. So it not only suppresses them, because they tend to get quite irritated when there's inflammation. So it brings down them, plus it also vasodilates. But they usually, because there's so many risks that come with those kinds of infusions, a lot of the time they require going into hospital for them for a period of time. It's usually about 3 to 7 days, depending on the duration. And surgical intervention, if we run into a point where we just can't heal them, there's too much pain, the infection's not going away. In some instances, I've had about 5 or 6 in my career where we've had to actually go in and surgically remove a portion of the fingers, just because we've tried everything we could try, and it's just not getting better, and it's influencing their ability to function every day. The pain's too much, the infection's constantly putting them at risk. So we sometimes, in some instances, we're left at a point where surgical intervention. So the ulcers, some of you guys know these really well, some of you hopefully not. Not only does it affect the knuckles, but also, again, the lower limbs as well tend to be, yeah, I saw a few bandages of those who came in today. So again, the same kind of dressings and the same principles ultimately apply to these ones. Just the vasoconstriction is not as, I'm not going to say not as significant, it's just not at the very, very end of something, but the circulation does still play a piece. Oh my gosh, water. Now I'm just trying to rush through so I could get through my time. One of the other things we tend to do, because the swelling in these instances becomes so much, that sometimes we'll use some compression, just light compression. It kind of sounds like you're counterintuitive. You're going to put more pressure on it, but what it does is actually move this move the edema out that's putting pressure already, and it helps it go back up to the body for your kidneys to work with. And I think I'm almost done. Okay. I think this is. So those are the dressings. So those are the polymems. They're really quite convenient in the fact that they're already in like finger form. So they're nice. They slide on. They're good. They can stay on for 7 days. I'm just claiming it now. I don't work for them. I don't get any money off of recommending them. I'm saying this is what works for my patients. The Manuka honey as well, and polysporin. If it's only like 7 days, I don't like polysporin as a regular go-to. If it's longer than 7 days, polysporin is not the thing for you. It starts, your body actually absorbs it, it's an antibiotic, and you can actually start to build a resistance to bugs, and then you got a bigger issue down the road, because then you have resistant bugs now starting to grow in your wounds. So if you have it and you're putting it on for more than 7 days, because that's all that you got in your med cupboard and that's what you're gonna do, 7 days, after that, I would say tap out, start looking at other options. And patient-centered. So again, we always say the best therapy is a therapy our patients are actually going to do. I could list all kinds of fun and exciting things that you guys can do, but if you're not going to do them at the end of the day, then what's the point? So you guys are a big part of how we plan care, what we're going to do and what's going to work for you ultimately. And multidisciplinary. Again, I'm sure you guys today get a chance to talk to many different disciplines about many different things. My team that I work with very closely, I have a rheumatologist, I have an orthopedic surgeon, I have a vascular surgeon, plastics, vascular, rheumatology, dietitians, OTs, PTs, and we really, even that at the end of the some days, it's just starting to make a difference. So all those people are very, very important when it comes to healing wounds.